Hello. I'm Michael Pinsky, and my co-chair is Audrey DeYoung from Montpellier, and I'm from the University of Pittsburgh. And we're going to be starting the session now. The session is quite exciting. It's on prone positioning, and we have some amazingly good experts who have been working in this field for a long time. And it's my pleasure to invite Marcelo Amado from Sao Paulo, Brazil, to give the first presentation. You have 15 minutes, and he's going to be talking on guiding the use of EIT, which stands for electrical impedance tomography.
Thanks, Michael. Good morning, everybody. So, prone positioning guided by electrical impedance tomography. So for prone position, this old physiology is very important. The lung behaves like a semi-liquid body with hydraulic forces where we have superimposed pressure. Keep this in mind, proportional to the height of this column of liquid-like substance, which is the lung, and the density. So, and this explains these old findings of Luciano Gattinoni, the wet sponge concept, where the densities, they obey the gravity forces. Very quickly in this case. Very recently, we have revised this idea because we thought that we needed new information about the dynamics of this. And in this recent paper, we had pigs monitor very intensively in supine and prone. And then we measured the amount of collapse at each position. And so this is at a high PEEP, no collapse supine and prone. Low PEEP, a lot of collapse in dependent lung areas. And surprisingly, very surprisingly, we found the same amount of collapse in both positions if you were operating at a low PEEP level. And this is a little bit against the old dogma. When we did it with EIT, we could see the progression of collapse in supine. So a little bit of overdistension at high PEEP. We decrease PEEP level, and we start to see collapse in the dorsal parts of the lung. So you have this sequence of events. And then we did it in prone, the same thing, and pay attention to what happened to the collapse. It goes ventral. So because this image should be like this, right? So again, we are obeying gravity. We have hyperdistension in dorsal areas and a collapse in ventral areas. But the same amount of collapse, okay? And surprisingly, also same amount of overdistension. Every time we measure with EIT, we measure the same amount of overdistension in prone and supine. So the old idea that overdistension is less comes from CT and comes from an artifact. I don't have time to discuss this, but we can discuss later. So you could say, is there any benefit? Because we just had an opposite axis in terms of gravity forces. So when going from dorsal to ventral, prone increased densities in ventral and supine increased densities in dorsal. But it's exactly the same gradient, the same amount of collapse. So which is the advantage of prone? So the collapse obeys gravity. Collapse happens independent, hyperdistension in non-dependent. But then how explain that the blood gas is very different? The explanation can be found in physiology of perfusion, the physiology of perfusion. And for instance, in this paper, we did bedside perfusion in COVID patients, in supine, and then in prone. And as you can see, perfusion was always dorsal. So in contrast with lung collapse, perfusion does not obey gravity. And as a result, you have more shunt in supine because you have higher perfusion in poorly ventilated areas as compared with prone, because now the perfusion is dorsal where ventilation is better and the lung is aerated. So the blood gas is better just because of a better VQ match, but not because of mechanics and not because of something intrinsically better in prone in terms of lung protection. So, is there really a protective effect of prone? In one of the first studies using a finite element mesh analysis of simulating the ribs and the elastance of the thorax and the lung, these physiologists, they came to the conclusion that when the animal was in supine, the ventral to dorsal axis was much larger than in prone. And then the lung gets longer and shorter in terms of ventral to dorsal distance. This is very important. We repeated these results here. So this is a CT of a pig, supine and prone. You can see that if we compare the ventral to dorsal axis, it is 2 centimeters shorter in prone. And in humans, we found the same thing, even a little bit higher difference. And then when we compare the craniocaudal distance, it's 5 centimeters difference. So the lung gets longer, 5 centimeters, as shown here across different PEEP levels. 5 centimeters longer, 2 centimeters shorter. And as a result, remember about superimposed pressures. Height times density. Because you are longer, density are lower. And because you are shorter in terms of ventral dorsal distance, then the height is smaller. So as a result, superimposed pressures, the gradient of pleural pressure is 9 centimeters in supine and half of this in prone. So these tiny differences in dimensions explain everything. This is amazing, huh? It's just physics. The consequence is very remarkable because this is the PV curve. This is the PV curve of this region and this region here. So the red region is dependent, displaced to the right. If you do the derivative of the PV curve, you have the compliance curve. And this is the distribution of pressures. It's like a histogram of units of the lung. So the blue units, they have a peak of compliance. So they have a concentration of units with closing pressures at this level and the red ones at these pressures. Why this is important? Because if you think about the whole lung compliance, is the sum of both curves, right? The blue zones and the red zones, and then you have to sum these two normal distributions, and then this is the peak of lung compliance. Okay? Now, if you have a higher gradient, you have a displacement of these normal curves, and then if you sum the two curves, you have a peak of compliance at this PEEP level that is lower. And this is why when you have more heterogeneity, the overall lung compliance decreases. So, as a result, more heterogeneous, lower compliance, higher driving pressure. This is proven in an old study where they had parabolic flights. Whenever we had zero gravity, lung compliance increased. And then you have hypergravity, lung compliance decreased. So just increasing the gravity forces, you can make the lung more heterogeneous, less overall compliance. So as a result, if prone is decreasing heterogeneity because of the dimensions, you have a better lung compliance. And this is proven in our animal study. This is supine, prone. As you can see, the peak of compliance at a PEEP level of 12 is higher in prone. So you can achieve better lung compliance in prone than in supine. And the same was found in humans. And the reason is found below. You have the dependent compliance against PEEP curve, and the non-dependent one, they are the peak of both, they are very close. But if you look at supine, the two curves have peaks that are very displaced. So as a result, when you sum these two curves, the overall compliance gets worse than in prone. So prone it's much more likely to have a good PEEP in prone because all the units are going to be happy at the same PEEP. In supine, it's very difficult to find a PEEP that makes everyone happy. So, is there a protective effect? Yes, because you have increased homogeneity and lower driving pressure because you have better compliance. Do we need less PEEP? Then this is very complicated. We tested using EIT, and as you know, the results of EIT are identical of the results of CT. And then when we measured the ideal PEEP in supine, we found 14, for instance, in this particular case. But in this same animal, in prone, the ideal PEEP was 20. So in some animals, the ideal PEEP in prone is higher, but it could happen in every way. Sometimes it's lower, sometimes it's higher. It depends on your particular anatomy, which is related to the anthropometric measurements. So prone may increase PEEP requirements. Watch out the cases of prone deterioration. Every time I see a sudden deterioration in prone and physicians were trying to put the patient back in supine, later on, I did it again and titrated PEEP, and these patients were like this. They needed much higher PEEP, like in this patient. When we turned him prone, he had a massive collapse in ventral regions because the belly was compressing the lung. So every patient behaves in a different way. And some patients have more overdistension in prone. So it could be every way. So it could be you can have more collapse or you can have more hyperdistension. You have to retitrate PEEP. So do you need less PEEP? No, it depends on patient anatomy or anthropometry. And I believe that an improved PF ratio in prone should not trigger a lower PEEP level because PEEP should be guided by mechanics, not by FiO2. And otherwise, you are going to have a higher driving pressure and you're not going to obey to this protective effect of PEEP. So in this paper, for instance, we used the conventional PEEP, low PEEP, and when we turned the patients prone, many patients had an increase in driving pressure. Why? Because we did not titrate PEEP. When we did it, we had a half and half, increase and decrease in driving pressure. So there was no consistent increase in driving pressure. So if you don't titrate back the PEEP level in prone, you may cause some harm for the side of overdistension or for the side of improved higher collapse. Look at overdistension. This is when we do not titrate. We have many patients that had more hyperdistension, but when we titrate, we improve the situation. So does prone, and this is my last topic, does prone work as a recruiting maneuver? And how long it takes? So when you're supine and you turn to prone, we know now doing sequential CT studies that you have a progressive dorsal recruitment and you have a progressive ventral collapse. If you do not make any special PEEP strategy, okay? And then when you are going to be supining the next day, you have again the same process and you are back to zero. So the net gain is zero. And this is why we see this sequence of PF ratio, turning prone, supine again, prone, supine again. So if you don't have a PEEP strategy, you are in trouble. But if you have a PEEP strategy, you can do something like this. You turn to prone. The first thing is because of lung hysteresis, and you can titrate PEEP again, you are going to have dorsal recruitment and maybe a little bit of ventral collapse. And now, if you're smart enough, you titrate again. For instance, you can, and I like to increase PEEP first and then decrease again, optimizing later. If you increase PEEP again, you are going to recruit the dorsal, the ventral region, and now we are not going to have dorsal collapse again. So by doing this strategy, you make use of hysteresis and a good PEEP strategy. And this is what we did in this study. This study was published a few months ago. It's a long-term study using EIT in patients with severe COVID. And then we could decrease the need of prone positioning and the repetition of prone positioning. And as a result, we have a better compliance as compared with any other protective strategy. So this is my message. Prone position monitored by EIT has been something very interesting, because you can make, I think, the best use of prone, and you can really make every single prone, let's say, any single prone event successful. I would like to finish, I don't have time, but my next, I had only 2 slides to show about the dynamics of the recruitment, how long it takes to have this good result. And EIT also is a very good strategy to monitor this recruitment in dorsal lung regions. And depending on the results, you may prolong the prone position up to 2 or 3 days. Thank you very much.
Thank you very much, Marcelo. We don't have much time for questions, but I have one, and if there's one from the audience afterwards, we can have that as well. Obviously, you can't change physics. Gravity is gravity. But what you can change is intra-abdominal pressure. Because unlike doing an animal that's walking around on 4 legs and is always in the prone position normally, they don't have the abdominal pressure compressing. So you mentioned anthropomorphics. Is there any benefit in measuring intra-abdominal pressure in the titration of PEEP in these patients?
Oh, this is a very good question. I think so. It is absolutely true that every time we have increased abdominal pressure, we have more tendency to lung collapse. But if you are really measuring collapse using EIT, you are already accounting for this. So when you're measuring this compromise between collapse and overdistension, you are accounting for the abdominal content.
But if you don't have EIT, can you just measure intra-abdominal pressure?
Absolutely. And then if you have higher abdominal pressure, you have to use higher PEEP.
Thank you. Any other questions from the audience? Thank you very much.
And now I'm very happy to introduce Professor Xavier Monet from Paris, France, who is going to talk about hemodynamic effects of prone position. Thank you.
Thank you very much, Audrey. Good morning to all of you. And I first disclose these conflicts of interest. And let's imagine a patient with ERDS on day 2, for instance, on pneumonia. And this patient is ventilated with a high FiO2. He has received a quite large amount of fluid and is under vasopressors. But blood pressure goes down. And for knowing what's happening, you perform a cardiac echo and observe right ventricular dilation that was not present on the day before. This is acute cor pulmonale. And one of your colleagues suggests to use prone positioning to solve the hemodynamic problem. And indeed, we use more and more prone positioning in our patients, and it's now clearly recommended by this consensus conference of the European Society. And it's mainly based on the survival benefit demonstrated in the PROCEVA study. And indeed, and we heard that it's perhaps more complex from Marcelo Amato, but we think it's mainly due to the respiratory improvement, but I would like to show you that it may be due also to some hemodynamic improvement due to heart-lung interactions. What are we speaking about? How does prone positioning improve hemodynamics? In fact, when you prone a patient, and that's very important, you first lower the trunk and then, of course, turn the patient. And this may significantly affect the cardiovascular system. And in fact, when you prone the patient, you may, depending on the patient's condition, increase cardiac output or have no effect on cardiac output or even decrease cardiac output in some conditions. And this is basically due to different pathways that we summarized with Jean-Louis Teboul and Christopher Lai in this review, which may look a bit complex, but which I will try to simplify. The first pathway is that prone positioning, by increasing intra-abdominal pressure, may increase cardiac preload and then cardiac output in case of preload reserve, of preload responsiveness. And this increase in cardiac preload, in fact, is due to two things. The first is that you first lower the trunk, and we know that it transfers a significant amount of venous blood toward the cardiac cavities as demonstrated during passive leg raising. And the second effect, indeed, is that it significantly increases the intra-abdominal pressure, as just said by Professor Pinsky. This effect is significant. These are two studies with Mathieu Josviak and Christopher Lai that we have performed in our unit, where we, in ARDS patients, we measured hemodynamics with a PA catheter and with echocardiography. And in both studies, we observed a significant increase in intra-abdominal pressure. This is significant. This increase in intra-abdominal pressure is transmitted to the splanchnic vasculature. It increases the mean systemic pressure, the forward pressure of venous return. It tends to increase the pressure gradient of venous return, tends to increase venous return, and then to increase cardiac output. And indeed, in this study with Christopher Lai, where we measured the mean systemic pressure, whatever the way with the ventilator method described by Professor Pinsky years ago, we observed a significant increase in the mean systemic pressure during prone positioning. This is significant. It's the equivalent of the increase induced by a 500 milliliter fluid bolus. Prone positioning acts like a fluid bolus. And indeed, the response of cardiac output or cardiac index here varies among the patients. And we observed that the increase in cardiac index was observed in patients with a positive passive leg raising test, which means in case of preload responsiveness, just as with a fluid bolus. Indeed, if both ventricles are preload responsive, the increase in mean systemic pressure increases cardiac preload, which reaches both ventricles, which is immediately transformed into blood flow. It means that the right atrial pressure increases less than the mean systemic pressure, exactly in a fluid-responsive like in a fluid-responsive patient. For instance, if mean systemic pressure increases by 16, the right atrial pressure increases less, the pressure gradient increases. That's why venous return increases. And this is basically due to the slope, to the waveform of the Frank-Starling curve, explaining a lower increase in right atrial pressure compared to the mean systemic pressure. On the contrary, if both ventricles are preload unresponsive, the increase in preload leads to a congestion in the cardiac cavities. It's not transformed into blood flow. The right atrial pressure increases more to the same extent as the mean systemic pressure. The pressure gradient increases less or non-significantly. And again, this is due to the slope, to the flat part of the Frank-Starling curve, exactly like during fluid infusion. And that may be my first message. Prone positioning increases cardiac preload by increasing the intra-abdominal pressure and mean systemic pressure. This increases cardiac output in preload responsive patients. That's the first pathway. The second pathway, which is perhaps the most important, is that prone positioning decreases the pulmonary vascular resistance, and this is first due to an increase in the pulmonary blood volume. Why? You all know the West zones, and especially this West zones 1, where the alveoli are compressed by the vasculature. And in fact, when you prone the patient, the increase in blood flow due to the increase in intra-abdominal pressure reaches the pulmonary circulation and increases the blood volume in these zones 1 vessels. This increases the diameter in zone 1. And so this decreases the pulmonary vascular resistance. In other words, on this representation of West zones that you may know, it means that by filling in the vessels, the pulmonary vessels, you decrease the zones 1, you increase the proportion of zones 2 and 3, you decrease pulmonary vascular resistance. This hypothesis comes from another study that we have performed years ago, not during prone positioning, but during passive leg raising, another way to increase the pulmonary blood volume, where also we observed this increase in the proportion of West zones 2 and 3. You understand that this may decrease pulmonary vascular resistance. But another way through which prone positioning decreases the pulmonary vascular resistance is by lung recruitment, decrease in hypoxemia, in hypercapnia. You all know that the increase in pulmonary vascular resistance during ARDS is due to multiple factors. Perhaps the most important, microvascular remodeling and thrombi, against which we can do nothing. But also hypoxic vasoconstriction, hypercapnic vasoconstriction, which may be significant, atelectasis, which increase the resistance in the pulmonary vessels, and ventilation and the PEEP level itself, which is not the only factor. Prone positioning may, if it induces recruitment, reduce hypoxia, reduce hypercapnia, induce significant recruitment, even if we heard from Marcelo Amato that this may be more complex than we thought, and perhaps allow you to decrease the PEEP level. And this may contribute, of course, to the decrease in pulmonary vascular resistance. Indirectly, this may improve cardiac output in case of ACP by reducing the size of the right ventricle. This unloads the right ventricle, and perhaps it's the most important effect of prone positioning. And indeed, in this study, for instance, we observed, look, this decrease in pulmonary vascular resistance, which was very significant in some patients. Prone positioning unloads the right ventricle. And this was translated in the reduction of the size of the right ventricle at echocardiography. So yes, likely your colleague is right to suggest prone positioning of this patient. In case of acute cardiopulmonary, this may be a good way to decrease acute cardiopulmonary in case of ARDS. And that's my second message. Prone positioning decreases pulmonary vascular resistance by decreasing hypoxia, hypercapnia, recruiting the lung, reducing West zones 1. It decreases the size of the right ventricle. However, there may be some deleterious effects of prone positioning, which is due to the third pathway. It may increase the resistance to venous return to a large extent in some patients. And indeed, it may happen in some patients that the increase in the intra-abdominal pressure reduces the size of the splanchnic vasculature, increases the resistance to venous return. And if it's larger than the increase in mean systemic pressure, you understand that this will eventually decrease cardiac output. There may be two risk factors. You understand it's more likely if there is a large increase in intra-abdominal pressure or if there is hypovolemia. And so you see that the effect may depend on the balance between the increase in resistance to venous return and mean systemic pressure. In fact, I'm speaking about a waterfall effect. And this waterfall effect, well described in the 80s, was well described in this animal during acute increases in intra-abdominal pressure, where you see initially cardiac output slightly increased but then decreased to this compression of the venous vasculature. And in this well-known study by Takata and Robertham, this occurred for a given threshold of difference of pressure between the intramural pressure of the IVC and the surrounding intra-abdominal pressure. This is not only theory. In the study I quoted before with Christopher Lai, we observed that. Let me enlarge a bit the figure. There were some preload-responsive patients where we expected an increase in cardiac output, but cardiac output decreased. And in these patients, it was just in a few patients, but the resistance to venous return increased to a large effect, and this was likely due to a large increase in the intra-abdominal pressure. And that's a second practical message. Be aware that when you prone the patient, this may decrease blood pressure, this may decrease cardiac output. To my opinion, I think it's a good argument for which we should monitor cardiac output in these patients, not only blood pressure, to know really what's happening when you prone the patient, and it's difficult to do that with echo in this position. And I think it's another good argument for measuring the intra-abdominal pressure, and perhaps be careful if the intra-abdominal pressure increases too much during prone positioning. Prone positioning may be poorly tolerated due to a decrease in cardiac output provoked by a waterfall effect phenomenon, especially in the case of high increases in intra-abdominal pressure and hypovolemia. Finally, today we use longer and longer prone position sessions, and it may be even for 2 or 3 days, we heard before. And so it's more likely that blood pressure goes down during prone positioning. And of course, the first solution may be to give fluid, but given the risk of fluid infusion in these ARDS, severe ARDS patients, you may say to yourself, I will likely test preload responsiveness. How do we test preload responsiveness in patients with ARDS? As we have summarized with Professor Pinsky, Professor Malbrain, the different tests and indices we have to assess preload responsiveness today. Some of these methods mimic a fluid challenge. Some of them use the ventilator. The main problem with during prone positioning is that we cannot use passive leg raising, which is the reference for obvious reasons, postural reasons. But another way that, and by the way, we also cannot use the inferior vena cava variations, of course. Another way that may be very interesting to mimic a fluid challenge may be this Trendelenburg maneuver. And indeed, when you put your patient in a Trendelenburg maneuver, you increase cardiac preload because you transfer some blood to the cardiac cavities. You change preload, just look at the change in cardiac output. And this other French team in Lyon with Jean-Christophe Richard showed that if cardiac output increased by more than 8% during prone positioning, during Trendelenburg maneuver in prone positioned patients, fluid responsiveness may be well predicted. Of course, you may also use, and I have no time to go through that, but you may also use the other ways, mini fluid challenge, in spite of its disadvantages and limitations, but also the other tests which use the ventilator, which are not affected by prone position, tidal volume challenge, and expiratory occlusion test and the PEEP test that we recently developed. My last message is, during prone positioning, fluid responsiveness can be predicted through the mini-fluid challenge, the Trendelenburg maneuver likely, and the other tests using the ventilator. Thank you very much for your attention.
Thank you very much for this wonderful presentation. Is there any question in the audience? No? If not, I have one question. What are the effects in patients with morbid obesity, especially in terms of increase intra-abdominal pressure? Is it safe for hemodynamic?
That's an excellent question. Two points. The first is that we know that obese patients do not always have an increase in intra-abdominal pressure, which is more due to acute phenomena. Second, your question means that we should be careful in patients with high intra-abdominal pressure at baseline due to obesity perhaps or other factors. Let's think about patients with ARDS and pancreatitis, for instance. In these patients, be careful. Monitor the intra-abdominal pressure just because it's elevated, and also because if you prone the patient, it may significantly increase and affect hemodynamics, as I said. So yes, we should be cautious in these patients with high intra-abdominal pressure at baseline.
Thank you. Any question?
No.
Yeah.
Question. If you manipulate with FiO2, do you decrease the glomerular resistance?
The question is, if I manipulate FiO2, may I decrease the pulmonary vascular resistance by reversing hypoxic vasoconstriction? Yes, likely, you're right. And so that may be another way, if possible, to decrease the pulmonary vascular resistance. The problem is that the range of improvement in PaO2 is usually quite small, the one you can achieve with FiO2. So my message is that yes, perhaps, but it's not the only way. Think about reducing hypercapnia, proning the patient, and all this, and perhaps reducing the PEEP level, but which is not the only way of reducing pulmonary vascular resistance. Thanks for your question.
Thank you very much, Xavier.
Thank you.
And now it's my pleasure to also invite Luigi Caponara, who's going to talk about the use of prone positioning in spontaneous ventilated patients. Luigi?
Thank you very much, and good morning, everyone. It's a real pleasure to be here today. And now we're looking at prone positioning in spontaneously breathing patients. So these are my conflicts of interest, but none of them are relevant for what I'm going to say next. And I'm just going to touch briefly on 5 points, going from physiology to the clinical benefits, patient selection and timings, and implementation challenges and what comes next. But let's start with physiology. And we've heard from Marcelo Mato that the two main mechanisms or physiological consequences after prone positioning. One is the redistribution of ventilation perfusion matching. You can see on your left-hand side in supine position, you've got ventilation and perfusion at the bottom. The two are mismatched. And as a consequence, we have more dead space towards the dependent areas and more shunt towards the vertebrae. And things obviously change with matching of the ventilation and the perfusion, leaving a more homogeneous ventilation perfusion matching. The other type of matching is clearly the ventilation and heterogeneity of ventilation. And if you look at the gas-tissue ratio there, in supine position, you can see the wide heterogeneity of gas-tissue ratio. And this is not the same in prone position, where everything is more homogeneous. And what is important is that if we have alveoli, theoretically, with the the same size and homogeneity, they can withstand more pressure, and therefore the lung is protected or more protected. The question is, does this happen in awake patients? Well, there is a lot of data. You can imagine they all come from COVID-19. So I tried my best to summarize some of the literature in some more diagrammatic version. So you can see what we can expect is clearly the PF ratio improves in awake prompt positioning. This is the range I could find in the literature, but on average 78 millimeter of mercury. But it's interesting, the PCO2 doesn't change. And you can see wide variation from a small decrease, this is in millimeter of mercury, to a little bit more of an increase. But the range of change is very small. But what we can see if we measure with electrical impedance tomography, that there is a better or reduction in shunt, this is in percent, and reduction in dead space, so leading to a better ventilation perfusion matching. And the other thing is that there are some data show that there might be a differential effect based on the lung morphology with a better ventilation, reduction in shunt in non-focal versus focal, and perhaps a reduction in dead space in the focal versus the non-focal. So these are the changes that we've seen, and some of these can predict outcome. So if you look at success of outcome, you can see that a continuous improvement in PF ratio, a reduction in shunt and dead space, and some changes in the ultrasound, particularly in the dorsal region, after the first awake prompt positioning or the following days, they seem to predict or be more associated with outcome. The other problem is effort. Clearly, these patients are awake, they're in prompt positioning. Gas exchange is important, but what is important is their perception of breathing. So what happens? So comfort, if you take comfort as a whole, doesn't seem to be changing. And why is that? Because we have some positive effect on the breathing, but also potential discomfort in maintaining a position which is not natural. Or it depends on the variety of interfaces that have been used in prompt positioning. But clearly the dyspnea, the sensation of breathing effort, goes down as it does the work of breathing. And these are data, when you look at the end expiratory lung volume, seems to be going up. The tidal volume remains the same, but there is on average, and this seems to be consistent, about 3 to 4, a reduction in 3 to 4 breaths per minute across the studies, with a reduction in stress. And if you take the tidal volume over the end expiratory lung volume, which is strain, that decreases. And again, the mean pressure time product, which is effect of effort, decreases as well. But there is a little bit more heterogeneity regarding the swing in esophageal pressure, with some data showing a decrease and some of them an increase. And this seems to be associated with intubation, so a reduction in shunt also seems to be associated with less intubation, and a reduction in the swings in esophageal pressure, less intubation. But there is a lot of heterogeneity. And the issues are this, because some studies use sedation, some others use different interfaces, and the time spent in prompt position varies quite a lot, as we will see later on, and this is a major confounding for effect in this population. So this is just briefly about the physiology, but what about the clinical effects? So this is a meta-analysis, and what you can see, this is mortality, and it doesn't take huge amount to comment that there is no effect on mortality when we combine all the data. And in fact, when we look at intubation, there seems to be a positive effect, so a reduction in the risk of intubation in patients who received awake prompt positioning versus the one in supine. But I would like to draw your attention to this, that this study is the one that pulls the data in the direction of a positive effect. So you can see only one trial, which is a combination of 6 trials, so it's a meta-trial that shows a reduction. We'll talk a little bit more about this in the following slides. So you can see that when you look at the heterogeneity there within the same trial, and you look at the 6 sub-trial, this meta-trial, again, of all the studies, only one within the same trial pulled the effect towards being positive. And this is for treatment failure, which is intubation and mortality, and particularly intubation. You can see all the ones across the unity. The only one on the left side of the unity is one trial. So that brings to the second section, which is patient selection. So now we've looked that the intubation is reduced, but perhaps is driven by one trial, which patients have been selected. So this is a combination that I put together just as a way of summarizing. So if you, apologies. So if you look at these outcomes, so intubation, again, you can see that it favors awake-prone positioning, but particularly in patients with advanced respiratory support, so high-flow nasal cannula or non-invasive ventilation, whereas there's no effect on the conventional one. And there seems to be affecting more patients within the ICU than patients outside the ICU. But let's look a little bit more in detail. This is another meta-analysis in BMJ, and you can see the overall effect of intubation is still the same, so reduction. But look at all the data of this meta-analysis, and what you can see, again, that only one out of all the trials are the ones that are determining this outcome. Let's see again, this is the selection of patient. So this is the, again, you look at intubation, positive effect, and you can see of all the trials, the one that used patient with a PF or SpO2 FiO2 ratio less than 150 is the one that showed the positive effect, all the others, no effect. Timing. Timing is important because if you look at this trial, and this is the one I mentioned earlier on, this is the meta-trial published in The Lancet, collecting essentially 6 different trials in Mexico, France, States, Spain, Ireland, and Canada. And you can see the most predominant one, 38% of the entire population, was the one in Mexico. So let's keep that in mind. You can see the Kaplan-Meier curve in favor of treatment failure. So in other words, there was less treatment failure in the wake-prone positioning, less intubation, more rapid weaning from high flow, but no change in mortality. And this is quite interesting because when you look at the time the patient spent in a wake-prone position in hours, from 0 to more than 13, and you can see that the blue is success, and the sort of orange-pink, depends on your color vision, is failure. And you can see there is substantially a higher proportion of patients in treatment success the longer they spent in prone position. And there's a wide variation in the individual trials. This is in the supplement of the study. You can see hours, and this is the sub-studies or the individual trials of this meta-trial. And what you can see that the Mexican study was the one with significantly higher number of hours spent per day. And this is quite important because when we look at other evidence, so this is a study comparing more than 8 hours in a wake-prone position and less than 8 hours in a wake-prone position, and you can see the difference in adjusted hazard ratio for survival without intubation and survival as well. And this is a very similar study, but again, different population, just to show you that's been reproduced across different population. You can see this is a prolonged wake-prone positioning, and by prolonged mean 12 hours versus a short, about 5 hours. You can see large difference in outcome. And again, some of this is dictated by their comfort. And you can see some patients who were dyspneic, so with hypoxemia, they spent fewer hours in prone position compared to the ones that were more comfortable. And that's quite important. But what you can see is that if a patient spent more than 8 hours a day, there was a 93% probability of treatment success versus 15% if they spend less than 8 hours. And clearly, the time spent in prone position correlated with greater success. And this is another study just to say that longer patients spent in prone positioning, the lower the odds ratio of mortality or intubation. This is another question. So we've looked at duration, but what about when to start treatment? And it's quite clearly that earlier the better. If you start early in the first few hours versus late, there is a difference in the survival functions of these two populations. But clearly there are challenges. And the challenges are implementation. And this is a study that published a bundle of care to achieve tolerance in awake prone position. And this was a bundle that includes sedation. They use some opioids and dexmedetomidine, monitoring and titration of the sedation to achieve a certain RASS score, good monitoring of blood pressure, and giving the patient some educational infographics so they could understand and comply. And you can see when this was achieved, there's a huge, significant difference in the intubation rate and invasive mechanical ventilation between the group who received this bundle and the group that didn't. And I'm going to skip this one. This is my conclusion. And this is what I could take from the literature. And clearly the evidence for some of this point is more controversial, but I'll give you this point. So when to use? I mean, moderate severe acute hypoxemic respiratory failure. There seems to be less benefit in patients with a milder disease or with conventional oxygen therapy. Early initiation. Sustained prone position for at least 6 to 12 hours for effectiveness. And if your intention is to reduce intubation, maybe when not to use it, milder, later stages, particularly when intubation is imminent, patients unable to tolerate more than 4 hours, and there are some patients who find it uncomfortable, or if your intention is to reduce the risk of death, that's not what the data show. When to become careful? I think that the interface and the comfort and the work of breathing associated with that is very important. Monitoring the response, particularly if ROX index or work of breathing deteriorates, or when there are some evidence of high inspiratory effort. But most of the data come from COVID-19, and it's difficult to know whether this is applicable to non-COVID-19. And we are going to do a study in the UK, Awake Prone, which essentially will recruit patients with non-COVID-19 acute hypoxemic respiratory failure and randomize them to awake prone position versus non-awake. And with that, my time is up, and thank you for your attention.
Thank you, Luigi, for this beautiful presentation. The comment you made at the very end is part of the question that I'm going to ask you. Clearly, the pathophysiology of COVID-19, at least early, was not to have a significant change in lung compliance, with a lot of shunt probably due to the vasculopathy associated with the infection in the lung. So if the failure of spontaneous breathing has to do with comfort, how do you predict you will see what's happening in non-COVID-19, where early on in the acute lung injury, we do see significant changes in regional compliance of the lung as part of the primary process causing the lung injury?
Thank you. Well, this is exactly why I think some of these data, particularly the one that are more controversial around the worker breathing or the delta esophageal pressure, they are more confusing. Because some of the studies, as you said, they enrolled just COVID-19, and some others were some of the mixed patients. And so the data are a little bit more, there's a more dispersion. In practice, I'm not sure how many people measure compliance in awake patients. Is probably very, very difficult. Maybe electrical impedance tomography can be, and one of the sub-studies that we're planning to do is use electrical impedance tomography in these patients. But we need to go maybe with asking the patient. Some markers of worker breathing, like ROX index, etc. And in this particular trial, is an effectiveness pragmatic trial. We won't be using any esophageal balloons, but it's a difficult one.
Esophageal balloons are tough, right?
Yeah.
Because they're spontaneously breathing and awake. But one of the things that Martin Tobin recommended 20 years ago was a suprasternal notch sensor that measured the change in esophageal pressure. I don't want to call it SUP or something, is what he called it. We don't use that, but I've been constantly amazed, and he thought it was one of the best things he ever invented. And I agree. It is a very nice way of measuring esophageal pressure swings, and I don't think it's commercially available now, but it is the sort of thing that if you wanted to jury-rig it yourself in an intelligent program, you probably could develop it yourself as well. And it's simply measuring the change in the esophageal pressure at the suprasternal loss, because that does transduce intrathoracic pressure, and maybe you should consider that in your study, because first of all, there's literature supporting it, and it's totally non-invasive, and it doesn't bother a spontaneously breathing person.
There's one thing that's very interesting. One thing we're doing, we've got some nanotechnologies. They are strips you can use around the nostrils, around the muscles, and they detect stress. Might be that's something to look into the future, some nanotechnologies.
Thank you very much.
Thanks.
And now it's my pleasure to introduce Mathieu Schmidt from Paris, France, who is going to do a provocative talk. Should we abandon prone position during veno-venous ECMO? Thank you.
So, thank you. Good morning, everyone. So, I'm very happy to be with you today to discuss if we should abandon prone positioning during VV ECMO. So here are my disclosures, mainly some link with company which are developing extracorporeal device. So the question that we're going to discuss today together is, should we continue to prone patients that are already on VV ECMO? So it means that we have a very severe patient, refractory to several interventions, get a VV ECMO, and the idea might be to continue to use prone positioning in this patient on VV ECMO. And this idea came from two landmarks LCT showing both that that these two maneuvers, ECMO on one side and prone positioning on the other side, are two efficient way to enhance ventilator-induced lung injury prevention. So combining these two techniques or pursuing prone positioning on ECMO has been used by many teams in the world with many observational studies published in the last decade. All these studies were showing almost the same signal, suggesting that combining prone positioning plus ECMO VV could be associated with a lower survival, with also a shorter ECMO duration. However, all of these studies published so far in the last 10 years were observational studies. So at some point, you need to try to confirm this potential positive impact of prone positioning on ECMO. So the prone ECMO trial was the first RCT in this field, and the idea was to determine the effect of early prone positioning during VV ECMO versus supine positioning on time to successful ECMO weaning in patients with severe ARDS. So patients were on VV ECMO, whatever the reason, but we strictly tell the participant to follow the guidelines and the European guidelines, especially. So patient were on VV, and then the patient was randomized either to go into the prone ECMO group, meaning that the patient will receive at least 4 prone positioning sessions early on during the first week of the management of this patient, so a minimum of 4 prone positioning sessions, and patients who were randomized into the supine ECMO group stay on supine until they were weaned from VV ECMO. The primary outcome was time to successful weaning within 60 days following randomization. The first challenge that we got was, first of all, to define what is a successful weaning, because there is no official definition of what is a successful weaning of ECMO. So we defined it. We decided to take quite a strict definition and to define it as a survival without ECMO or lung transplant for 30 days after ECMO discontinuation. So you need to stay alive 30 days after being decannulated. We analyzed 2 competing events: weaning failure, meaning patient who died within 30 days after being decannulated, or those who died while being on ECMO. And the primary outcome was quite disappointing, or at least quite very different from the observational studies that we got so far, with almost no difference, in the primary outcome, exactly the same rate of successful weaning. Even if you analyze the 2 competing events, death or weaning failure, no difference at all between the 2 groups, and for none of the non-secondary outcomes were also different in the 2 groups, and even if you dig further by analyzing some subgroups, we didn't find any difference between these 2 groups. So the conclusion was quite straightforward. Among patients with severe ARDS supported by VV ECMO, prone positioning during ECMO did not significantly reduce time to successful weaning of ECMO. At that stage, should we throw the baby out with the bathwater? So it means that should we continue to prone ECMO patient? If yes, for which patient should we do it? And I will try to summarize what we have learned with this trial. First of all, I will probably continue to prone on VV ECMO if my patient has not been prone before being on ECMO. And one of the specificity of the prone ECMO trial is to see the very high rate of prone positioning before being on ECMO. So very high rate, which is great, which means that the guidelines of ARDS management were strictly followed, but maybe explained also by the time period of these studies. And this is probably one of the main differences between the observational study and the following RCT, is that when you look into the observational study, you see that the prone positioning rate before being on ECMO was quite low in this Italian cohorts. Even I show you other study, in this study from Marseille, which is also belonging to the meta-analysis, you see that in the prone ECMO group, 68% of the patients were prone before being on ECMO, and even if the landmark RCT, the Eolia trial, you see that only 56% of patients randomized into the ECMO group receive prone positioning before being on ECMO. So maybe this could be the first difference, suggesting that if my patient has not been prone before being on ECMO for any reason, probably I should continue to prone I should at least start first to prone my patient on ECMO. I will still probably continue to prone on VV ECMO patients who are non-COVID-19 related ARDS, because even if this prone ECMO trial was not designed for COVID-19 patients, the other of life makes this study start in the middle of the pandemic. So as a result, you see that most of the patients included in this prone ECMO trial had a COVID-19 pneumonia. when you say COVID-19 pneumonia on ECMO, it means that you expect quite a high mortality. Look at the mortality at 90 days, roughly 50%. And we know that this patient, especially this very severe patient on ECMO with COVID-19, one of their characteristics, especially during the Delta variant, was to have a very, very prolonged ECMO duration, very long stay on mechanical ventilation. You see that more than a month on mechanical ventilation, nearly 1.5 months in the ICU, and nearly 2 months in the hospital. And this is not classical. I mean, for patients who have no COVID-19 related ARDS, usually the ECMO duration is shorter. So you see, I just give you, for comparison, the median time on ECMO in the OLIA trial. You see that it was 15 days. So maybe we can guess, that longer ECMO runs means also more time to accrue other problems. And we know that problems related to ECMO are quite significant. You have bleeding, you have superinfection, you have many things could happen during a long ECMO run. So maybe this very long ECMO run and all the potential complication induced by ECMO could neutralize the impact of an early intervention. So we can maybe think that a non-COVID ARDS patient would respond differently. And especially what is interesting is to look at the compliance, the evolution of the compliance at day 2, day 7. So it's not significant between the two groups. However, if you follow the day-by-day compliance over the first 7 days, you see that with on supine position, progressively you see that when the patient stays on supine, the compliance of the respiratory system will progressively decrease. Over the 7 days on ECMO, for the patient who are on prone positioning, the compliance seems to stay stable. So obviously it's secondary analysis. The p-value did not cross 0.05, but maybe with a disease, when you expect a shorter ECMO duration, maybe doing prone positioning may significantly impact the outcome. I will still probably continue to prone a patient on VV when you have a CT, a thorax CT, which give you some signals suggesting that this patient might be a responder. So we had a beautiful lecture previously. So I will go quickly on that. But what we have shown is, not surprisingly, patients who gain compliance when they were prone on ECMO are mainly patients with obviously dorsal collapse, but also with still preserved aerated ventral and media ventral zone. These images were found on a CT. For which patient I will not continue to prone? I will probably not prone patient on VV ECMO if, first of all, they have a COVID-19 related ARDS. I think this prone ECMO trial, even if it was not specifically designed for COVID-19, show that if you do it with COVID-19 ARDS patient, it doesn't work. I will also not prone on VV ECMO if my medical and nursing teams are not experienced. And this is a very important point. We include only centers who got experience of this procedure. This is not so complex, but you have to train your medical and nursing staff. And this study showed that proning on ECMO was quite a safe procedure with almost no complication, no ECMO decannulation, no non-scheduled extubation, no severe hemoptysis. So it means that the safety of this procedure was proven by this RCT, but again, we include only centers who were experienced with this procedure. And as it's already stated for ECMO, ECMO should be used in ECMO center, which meets a defined organizational standard adhering to a management strategy similar to that used in the OLIA trial. So it's part of the ECMO management. If you do prone positioning on ECMO, you should have training before. I would probably stop proning patient on VV ECMO when the tidal volume is extremely low, and you know that some patients have complete collapse of the lung. So in that extreme patient, but quite frequently seen on ECMO, does position matter when ultra-lung protective ventilation, which means you have a very limited aerated of the lung, is already performed? Does it make sense to prone this kind of patient? I don't think so. And this is probably which is also suggested by the prone ECMO trial. When you focus on the tidal volume at the time of randomization, you see that the median tidal volume was 3 ml per kilogram. So it means that these patients were already ventilated with ultra-lung protective ventilation with the idea to reduce ventilator-induced lung injury. But you see that some patients had a very, very low tidal volume. More than 25% of these patients, including the prone ECMO group, had a tidal volume lower than 2 ml. This is also suggested by another study published recently in 2022. This study was a study with a lower number of patients included, 38 patients. But the idea of this study was to compare two strategies of ventilation on VV ECMO again, a classical, let's call it classical mechanical ventilation setting, so meaning following what has been shown in the earlier strategy, and one other strategy which was much more aggressive in terms of lung protection, meaning with a tidal volume reduced to 1 to 2 ml per kilogram, a respiratory rate very low, between 5 to 10, and at least one propositioning session. And this strategy, interventional strategy, was compared to what is usually usually done with these Eolia settings. Even if the primary outcome of this small RCT was mainly respiratory mechanics and inflammatory cytokines, we can be could be very interesting to focus on a secondary outcome, which has mortality, which show a much higher mortality in this strategy when the tidal volume was very low and the prone positioning was also performed in this group. So actually, what could we conclude? At least now in 2025, prone positioning on ECMO should not be done in patients with COVID-19 related ARDS. We have a RCT which demonstrates that. If prone positioning has systematically been performed before ECMO, it didn't show any benefit. And when ultra-lung protective ventilation is already performed, probably it's maybe not so relevant to continue to prone. Do we need a non-COVID ARDS prone ECMO RCT? Probably, because a shorter ECMO duration could magnify the impact of this early intervention, but this is the future. Thank you for listening.
Thank you very much. I have one short question. Is it not a mistake not to perform prone position before ECMO? I was quite surprised by the huge amount.
Obviously, it means that you did not follow the guidelines. But it's always that. When you see the guidelines, when you see what's happening in real life, you got this ratio. And probably after the pandemic, maybe now the rate of prone positioning before ECMO should be close to 100%, which is probably what we should target. But in real practice, in real life, it's sometimes we have patients who did not receive prone positioning before ECMO for hemodynamic reasons, there are several reasons which could explain why not.
So Matthew, I have one quick question that has to do with the comment. One of the things we know happens when you go on to VV ECMO is that your pulmonary vascular resistance decreases significantly under most conditions, improving right ventricular function. However, in several patients, it doesn't occur, and they do get increases in pulmonary vascular resistance. And we know that in those patients, prone positioning has a beneficial effect. So In your studies, did you perform echo and look at right ventricular volumes compared to left ventricular, just the diameters? One doesn't have to get fancy here. And do you plan on doing that in the future studies?
Yes, we definitely plan to use it, to do it in the future study, to do EIT with ventilation perfusion as well, to try to demonstrate this. I totally agree with your point. In the PRONECMO study, we don't have, quality data on the RV function, unfortunately.
Any question in the audience?
All right. Well, first of all, I want to thank the 4 speakers for amazing lectures. This was highly insightful, and for the audience for your participation. We call this session to an end. Thank you.